Good evening and welcome to yet another Grand Rounds podcast, if you will, live session. This is the Zev Zelenko Memorial Series dedicated to the memory of Vladimir Zev Zelenko, our late colleague who was an inspiration to all of us for his dedication to healing and to science. We are in an unusual period of medical history where much of what we thought we knew and learned has been uprooted, and we have to start from scratch in many ways, all the while retaining some of the good stuff from real medicine, such as the real basic sciences like biochemistry. We've mostly had doctors presenting, and last time I think we had a PhD science journalist, Nina Teicholz, and that was fascinating. She knows more about nutrition than the vast majority of doctors that I know, and she gave us very interesting perspective. And it's time that we start to broaden our reach and bring in some non-MDs who are out there doing a lot of this groundbreaking work, reinventing medicine. And one of those is Stefan Hartmann, who is a PA. He's someone who I've gotten to know pretty well over the last half a year or so. I've actually gone to visit his practice down in Melbourne, Florida. And I've watched several of his presentations, and they've all been extremely interesting and very well done. So I thought he would be the right person to bring in and talk about a different aspect of what's going on in medicine today. Um, his title of his talk is Muscle Centric Medicine. So Stefan, in addition to being a healer, is an athlete. He's a semi-pro tennis player. He's a serious bodybuilder, and he practices what he preaches, which is very rare today. The other person that comes to mind is Sean Baker, very famous carnivore who was, a super athlete. So his talk is going to be Principles of Exercise Science, Muscle-Centric Medicine. His basic thesis, I believe, is that you can heal a lot of metabolic woes by getting your muscles back and getting your muscles in shape. And I'll let him take it away. We'll have time for questions at the end. I also want to welcome as to the panel my colleagues, Dr. Brian Atkinson and Dr. Dana Granberg-Nill, and some other distinguished physicians, members of Goldcare. So, Stefan, it is all yours.
Excellent. Thank you, Luke, for that excellent introduction, Dr. Amerling. Let me share my screen here and we'll get started with the muscle-centric medicine approach. You can't see it behind me, but the sign behind me says muscle-centric medicine. So every patient that sits in front of me and sees it has this branding in front of them because it's, as we're going to learn today, you can reverse a lot of diseases with it and you can prevent a lot of diseases from happening. Because what we're dealing with primarily is metabolic disease in the US, as some of the recent surveys have indicated that perhaps only 12% of the population is metabolically healthy, and increasingly, even the younger population that previously we didn't think are unhealthy, they have insulin resistance. This is age 18 to 44. This is happening younger and younger, and this can all be prevented with the principles of exercise science. So some of the things we're going to learn about today are the mechanism of action behind this, and then how you can implement this for your patients, how they can obtain a good physique through setting goals, tracking progress, building a program, consistency, nutrition. We're going to talk about the different type of muscle fibers, the different type of exercises that exist, compound, accessory, and a lot of popularized modalities out there. So what are the benefits of building your muscle? Besides the obvious where, it looks good. Besides that, you can potentially reverse autoimmune illnesses. Look at Dr. Terry Wowell's story on multiple sclerosis. Pretty powerful testament to how that works with just Paleolithic diet and strength training. It improves your immune resilience to common colds, viruses, bacterial illnesses. It'll lower your blood pressure, improves your HDL, lowers triglycerides, improves your insulin sensitivity, so that lowers your diabetes risk, which, diabetes is an all-cause mortality problem. It reverses non-alcoholic fatty liver disease, which is on its way to becoming the #1 reason for liver transplantations in the US. It improves bone strength and reduces fracture risk in the elderly. Decreases visceral fat, so that's fat on your organs, your heart, your liver. And even decreases cancer-related deaths. So here's some of the mechanisms for this. Increased glucose disposal. The skeletal muscle is a major player in how you and the food that you eat. Where does it go? Does it just sit around in your bloodstream, causing problems, causing inflammation and damage to your arteries? Or does that energy go towards proper storage in the muscle? GLUT4 translocation. Resistance training stimulates the movement of a specific glucose transporter called a GLUT4 from storage sites within the muscle to the cell surface. And training consistently improves this adaptation. The muscle is an endocrine organ, like your pancreas even. It was thought of previously as a static device that just brings the beer can from the table to your mouth. No, the muscle, it works like your pancreas, works like a signal for your inflammatory response. We learned about this in the pandemic. The patients that did the worst with COVID, it wasn't so much the COVID killed them, it was their own inflammatory cytokine response to the COVID-like illness. When you have a robust skeletal system, your cytokine response to various viruses, Lyme, mold, you name it, next bioweapon they throw us, it is modulated through a very robust musculoskeletal system and a lower body fat percentage. Improved insulin signaling. So you improve your insulin receptors by strength training consistently. Increased glycolytic capacity. So resistance training enhances the muscle's ability to break down glucose for energy production through a process called glycolysis. So glycogen is stored in your muscle when you have good muscle system and you train consistently, and it's released in the form of glucose to sustain you during activity. It's kind of cool to see this when you're a highly trained athlete. The highest amount of glucose I've ever seen in my body was when I'm playing tennis, right? So that's kind of interesting, right? Kind of counterintuitive. You think the blood sugar would drop in chest. No. When I wore a continuous glucose monitor, what would happen is that my glucose would spike to about 130 and 140 when playing a competitive tennis match. Now compare that to eating, and I tried to increase my blood sugar as much as I possibly could. So I ate like 4 of these nice donut typey things that I got at a nice bakery, and my blood sugar would only go up to about 130. I ate about 4 mangoes in a sitting to see how high it would go. Mangoes have a ton of sugar in them, and my blood sugar would only go up to 140. So when playing tennis, I actually released more glucose into my bloodstream than if I had sat down and ate a bunch of fructose. So that just goes to show you, when you have a good, robust skeletal system, it stores the energy appropriately and releases it when you're training intensely, which is supposed to do. You also improve your mitochondrial function. So this is critical for, again, energy with the chronically fatigued patient. So overall, the combination of these effects increase the muscle size and endurance. It improves your ability to manage blood sugar and improves proper storage of nutrients in your muscles where it should be, rather than fat or on your organs. Let's take a look at some real life cases to understand the problem that we're dealing with. So this is a 28-year-old male with a fasting insulin level. He came to me with an insulin of 28 on a fasting blood sugar test. He was obese. He had low testosterone levels consistently. We put him on a diet training program with strength training, lowering the fructose, lowering the carbohydrate he was eating, and he gradually improved. He has a lot of work still to do, but this guy was on his way to diabetes, and he's only 28 years old. What happens when you have this? And what is happening physiologically? We have to talk about this. So there's compensatory hyperinsulinemia. When the tissues, primarily muscle, liver, and fat, start to become resistant to insulin, the pancreas compensates by secreting more insulin to maintain normal glucose levels. This results in a high fasting insulin level. Now, you can have a young guy like this, and he doesn't meet conventional criteria for diabetes. His fasting glucose is 101. Most primaries will be like, we'll just watch this, we'll check it in like a year or so. Your blood sugar is normal. It was 97 at this time. So you can see this guy didn't meet criteria for diabetes. His A1C was 5.9. Not great, but not diagnostic for diabetes either in a conventional primary care practice. So this guy was on a one-way ticket to Diabetesville relatively soon. The prediction is about 10 to 20 years that they develop full-blown diabetes. So yeah, it leads to progression of diabetes in about 10 to 20 years. And when you have this hyperinsulinemia, you have more cardiovascular disease. It raises your blood pressure. You have lower HDL. You have higher lipid particle counts. You have more weight gain. You have more fatty liver disease. Again, you have those all improper storage of energy problem that we see everywhere. Just go to Walmart and you're going to see it everywhere you go. People walking around, improper storage of energy in their adipose cells. This is a patient and an example of how young woman, 35 years old, has HPV dysplasia and insulin resistance. Fasting insulin levels of 12 and 13.8. Hemoglobin A1C, again, borderline 5.7, not criteria for diabetes. A1C 5.4, right? But high inflammation, CRP about 8, insulin resistance, and cancer, really. She has to potentially get a cervix removed because of this. Other complications for women, PCOS, very common nowadays. Breast, colon cancer, all sorts of problems when we have high insulin. Take a look at this mouse study here. I think this is a pretty nice illustration of what training can do. So they took tumors, they injected it into the mouse, but after exercise, there was reduced tumor formation when you exercised the mouse. It's a nice rodent model of what exercise can do for cancer. I know cancer is on all these functional medicine talks. Everybody wants ivermectin to be the winner here. We have to go back to the basics. When you have a patient come to your practice, they're like, I saw somebody said ivermectin worked for cancer. Look at their diet. Are they training? What's their fat on their body look like? I mean, the patients, they want a one cure, but you got to look how they get there in the first place. A lot of these cancers are metabolically driven. It's the unfortunate truth of the matter. Check their insulin levels. An optimal optimal level of fasting insulin should be between 2 and 5. You can do the HOMO IR calculation. This is the calculation here if you're interested in that. But a good rule of thumb is like between like 2 and 5 is optimal. If you're at 7, it's okay. If you're pushing above 7, you're getting to 10. And especially if you're above 10, you've got real problems there. Let's talk about insulin as the most anabolic hormone for bodybuilders, right? So we're going to talk about what they do here because I work with some of this population and I know what they do. So what does insulin do? It improves nutrient uptake and storage. Insulin promotes the uptake of glucose and amino acids into the muscle cells by increasing the activity of that GLUT4 transporter again. It improves protein synthesis. Insulin activates the mTOR pathway, which regulates protein synthesis. Never tell a bodybuilder to take rapamycin because it slows down mTOR. They'll run the other way. Bodybuilders love mTOR because it helps them grow. Glycogen synthesis. Insulin drives glucose into the muscle cells to be stored as glycogen. It has anti-catabolic effects. The timing is critical for the bodybuilders. What do the diabetics do? What does the endocrinologist tell the diabetic? The endocrinologist tells the diabetic, you need to eat carbohydrates so that you can do your insulin shot. What happens when you do this? When you use insulin in this way, just sitting around eating donuts, you store it as fat. This is why the diabetic type 2s, when you put them on insulin, they're like, you made me fatter. Well, how did you use it? So the timing matters when you give them the insulin. So this is what the bodybuilders do. What they'll do is they will they'll do a really intense training regimen. They'll drink about 100 grams of carbohydrate mixed with amino acids and protein in a shake, and they'll inject themselves with underground insulin for the purpose of being anabolic, because they'll tell you it's the most anabolic hormone. Forget nandrolone, trenbolone, anything else. They'll tell you insulin is the most anabolic hormone if you work with these guys. And that's because it's amazing for that. So this is how they'll use it. Pre-workout, you could use it potentially as well, and then post-workout. So we can tell our diabetics, if they have to use insulin because the endocrinologist says you have to use your insulin and you have to eat carbohydrates, tell them to use it in the peri-workout window. Specifically, after an intense strength training activity, you combine the amino acids with the carbohydrate and the insulin. But that's another story if you're going to use insulin in diabetics. So we'll skip that. So let's talk about what most of the population should be doing. Setting goals. So common, I get a female patient and they'll say, I want weight loss. I want to lose 10 pounds, Stefan. And I say, wait, wait, wait. We have to rephrase this. We want body recomposition. We want to change the ratio of muscle to fat. And to do this, I recommend getting abdominal MRIs of your patients. And you're going to have to learn this to read this yourself because unfortunately, our radiologist friends, they don't comment on visceral fat. And you'll see in an abdomen full of visceral fat, and the the comment will be normal abdomen. So me, even as a PA, I've had to actually learn how to read abdominal MRIs because I can't get our radiologist to comment on this. They'll read it normal when it's full of visceral fat. When it's not healthy. This is an independent risk factor for cardiovascular disease, cancer, nothing good. Other things you can do DEXA body composition scans. You can do abdominal ultrasounds to look at their fat on their liver. So something that's objective rather than just the scale. Because if you lose weight, you can lose bone, you can lose muscle as well. And that's the problem I have when patients ask me they want weight loss. So here's a DEXA scan. Great images here. Pretty cheap as well, cheaper than most MRIs. Other thing you look at, you can do blood pressure tracking, again, fasting insulin levels. All of these things will change, and they're hard markers that you can see change. So they're better than the what's it called? Scale, right? Because patients won't lose weight. I tell them straight up, if you do a strength training program, you won't lose weight because you're going to gain muscle and it weighs more than fat, and you're going to gain bone mass, hopefully, if you're a woman. And maybe eventually the fat will change, but that's not the first thing that changes. So again, BMI measurements give a false sense of health. Not a huge fan of these. Look at their visceral fat. When you do a strength training program, when you put them on a low carbohydrate diet, oftentimes they don't lose a whole lot of weight on the scale, but their visceral fat changes. When you measure their waist circumference, that changes. So that's a little bit of a better marker than anything else. This is what a progressive resistance training program might look like. You get an Excel spreadsheet, it's nothing crazy. You can now have ChatGPT make these for your patients. I did this back before ChatGPT when I was a personal trainer working at LA Fitness. This is an African American lady I had. She's 56 years old. She was 315 pounds. She had osteoarthritic knee. She had blown out all the cartilage in her joints. We started very slowly. We did, 3 to 4 sets. We did 8 to 12 reps, and she would do 60 to 7% of 1 RM. So you don't want to do super heavy weight. You want to do enough weight where it's difficult on the 10th, 11th, 12th rep in an exercise set. Then you take a break about 60 seconds and you go towards the next set and you do about 3 or 4 sets of that. And I ask her every time, how did you feel after that? Did anything hurt? You don't want anything to hurt badly. You want a little bit of muscle soreness in the next days. The consistency is key with these patients. Oftentimes, the patients are drinking their calories. They're drinking oat milk because they think it's healthy. They drink a couple glasses of wine a week because they think wine is healthy. Someone told them resveratrol is in wine and they should drink, wine for the resveratrol. Little do they know they're drinking 500 calories excess every week. And they say, I can't lose weight, Stefan. What's going on? Well, you're drinking your calories. Cut out the oat milk and cut out the IPAs. IPAs, by the way, are highly estrogenic, and all alcohol is estrogenic, and it's too much for them. Nutrition, calorie in, calorie out. Yes, calories do matter, but the quality of the calorie matters more. So you can have a bag of Doritos and it's say 160 calories, or you can have some eggs and beef liver. Which one is going to provide more satiety and more nutrients? Obviously, the eggs and beef liver compared to the 160 calories of Doritos. And the studies confirm this. When you put a patient on a low carbohydrate diet, they can independently of calories improve their visceral fat. So if you want to do the conventional calorie in, calorie out method, which it works as well, and I have had patients on an ancestral diet or a carnivore diet and they won't lose weight, and it's because they still can overeat. Somehow, certain patients can still overeat even on a nutrient-dense diet. So they do need to count calories. And now you have ChatGPT, you can go onto these precision calculators, you put in your weight, your height, you put the target weight that you want to be by a certain time, you put it into the calculator, and it tells you how many calories you need to eat per day to lose weight, to gain weight, or to sustain the same weight. You can also do this with BMR testing, so that's Basal metabolic rate testing is a breath analysis test, and it tells you how many calories you burn every day just sitting around. Everybody's different. Like, for example, myself, since I have so much muscle mass, my basal metabolic rate is 3,500 calories per day without exercise. I just burn a ton of calories all the time just sitting around here talking to you. And why? It's because I have a lot of muscle mass and a low amount of fat. And so my muscle requires a lot of energy to sustain itself. This is another thing I want to point out is when you have a lot of female patients, they won't want to pick up a dumbbell because they're afraid they're going to look bulky. And it's just not a true statement. I don't know where this came into being, but to get bulky as a female is almost impossible. You have to have the genetics for it. You need to be training really consistently for a very long time, and you need to be taking a ton of anabolic steroids to get that bulky look that you see on stage with female bodybuilders. It's just not possible for the general population. What will happen with the general population is that that bulk of fat around the midsection, it will shrink with time. It's not going to be overnight. It took probably a couple of years to gain all this fat. It's probably going to take a couple of years to lose all that fat. So you have to have some talk with these patients about this. Two types of muscle fibers, which I learned in my education in kinesiology. There's type 1, there's type 2. Type 1 is more in your endurance athletes, your long distance runners. Type 2 is in your bodybuilders. This is in your Usain Bolt, your sprinters. I prefer the fast twitch muscle fibers if you're going to train one. So if you got a busy schedule, you're seeing patients all day, and you have maybe 1 hour. Are you going to go run, walk, or are you going to hit the gym, hit the dumbbell press? You're going to hit the dumbbells every time if you only got 1 hour to train. Because the fast twitch muscle fibers, they take up more volume and they're going to require more energy. You're not a marathon runner. Why are you trying to run it all off all day long? So again, a little bit of a summary, why the muscle-centric medicine approach: improving glucose tolerance, improve insulin sensitivity, preventing fall risk with age, improving this cytokine response, you're literally improving your immune system. You're modulating the immune system. We talk about immune modulation with all these alternative medicine groups like Dr. Halassa's chronic disease prevention and management group and Dr. Clearfield's group on Tuesdays. They are using repurposed drugs, amlexanox, low-dose naltrexone, ivermectin, all these things to modulate all this inflammation that's going on in society. When we have the muscle, it's right on our body. All you need to do is train it, and you can control your hyperactive immune response to all these things that are being thrown at us. The chemicals in the air, the next bioweapon that Fauci's going to release, you name it. Now we need to talk about some of the other parts and why I practice anti-aging medicine along with muscle-centric medicine. It's because when you have an older patient, they're not going to respond the same as the 20-year-old, and they'll tell you that. Everybody knows that. It's obvious, but for some reason, it's not practiced in a lot of practices. You need to do hormone replacement in your older patient to give them a good result. Otherwise, they're going to lose interest. They're going to hurt in the gym. They're not going to recover as well. So growth hormone and testosterone, it increases with heavy resistance training in younger individuals, but in elderly women and men, they had no response to heavy resistance training. So yes, testosterone growth hormone increases when you're younger with training, but not when you're older. This is why we do need to do replacement therapy. Resistance training builds your brain. You have to talk to your parents about this. If you guys have older parents, they want to prevent Alzheimer's. Everyone's afraid of losing their brain with age. You need to strength train. When I have a gym in my back office, my backyard here, I'll bring my patients out there and I'll put them on Olympic rings. This is very cool to see this. I'll put them on Olympic rings and you'll see them like this when they push the rings and trying to support their body weight. It looks like they got Parkinson's or essential tremor. And it's because they don't have the neural connections from the muscle to the brain. So the patients, again, they ask, I want to lose 20 pounds. I want to look this way. No, the first thing that's going to grow is your brain. The neural adaptation happens over a couple weeks, couple months, depending on how deconditioned you are. But over that time, and I've trained patients out here in the gym, that shakiness, it becomes stable. And then at some point, they're doing smooth push-ups on the Olympic rings without the shakiness. And that tells me that their brain is actually getting smarter. And fMRI scans have proven this over many studies, is that their brain actually grows new white matter when they start any strength training program. Also 256 pounds beginning weight. lost about 50 pounds in the process. As sometimes the patients don't always lose those pounds initially. What they might notice is that their waist circumference starts shrinking. That's probably the quickest thing they might notice. But other things that she noticed was less edema in her legs, uh, more energy, right? Better sleeping, less hot flashes, improved libido, less inflammation, less brain fog. In the exercise program, she did hire a trainer who was doing cardio with her, was doing high intensity interval training with her, was doing weight training with her. She was also doing cold forge therapy as well. It's another story that reduces inflammation. This is another patient. He actually sent me a new picture. I think he even looks better now. He's lost close to 100 pounds over the course of 2 years with testosterone replacement therapy and strength training. Really, his diet didn't change that much. He was doing a pretty lean Paleolithic diet. This is a patient doing a DEXA scan over the course of the training. This guy actually would purposely do bulks, and the bulks, every time he did a bulk, so a bulking, I should explain it, is when a bodybuilder purposely consumes excess calorie to grow larger muscles. But in the process, they also gain some fat too. So this patient, he would sometimes yo-yo back and forth. I'm not a huge fan of bulking, actually, for this very reason. So this patient gained 22.5 pounds of fat on the bulk. So that was compared to the initial. Now, highly trained athletes like bodybuilders, they can lose the fat with a caloric restriction. But the problem is fat is forever. You can shrink the fat cells. You can't remove them unless you get liposuction. But that's another story. This is another patient. She came to me with zero exercise knowledge. She had chronic pain, inflammation, heavy cycles, high fasting insulin, high glucose. She was diagnosed by me with insulin resistance, prediabetes, estrogen dominance, low thyroid function, and other hormone imbalances. This was 3.5 months of progress. She was training at my gym 5 to 6 days a week. She's doing low carb keto. She said her anxiety was becoming controlled without medication. She lowered her fasting glucose. Her acid reflux went away. Her joint and body pain, it went away. The cycles regulated. The inflammation started decreasing in her face. That's what she noticed, is that her face started to shrink. There's less inflammation in the face. This is her glucose variability over the course of 3 months. So initially it was very high and then it came down. Her fasting glucose also came down consistently over the months as she kept training. So what is happening here? Most patients, they have too much energy and poor glycogen storage. And so this just results in them accumulating the glucose and fats in their blood, leading to all cardiometabolic diseases that we see every day in practice, at Walmart, wherever we may go. So what she noticed was improvements in the glucose, energy improved, weight loss, and her face changing, shrinking. This is what she noticed. Let's talk about the different exercises that we can do. We can do compound exercises. Compound exercises is where you put stress on the entire frame, where your legs are pushed into the ground or your back is under a lot of load. This targets multiple muscle groups. It causes a large central nervous system stimulation, especially if you do heavy loads. You will always activate your core muscles, your abdominal muscles, when you do compound exercises. So again, if you're a busy professional, you only have maybe 40 minutes a day to train or do an exercise. You want to do the bench press. You want to do the bent over row. You want to do the overhead press. You want to do the Olympic rings, which will show you with that as well. What are accessory exercises? This is where you target 1 or 2 muscle groups at a time. This is an example here. I'm doing the bicep curl. Biceps, well, you're curling. So you're only targeting pretty much 2 muscles, the biceps heads. You can activate the abs with proper technique, of course, but really it's less bang for your buck if you only have a short amount of time. Calisthenics, this is where you use your own body weight for training. So you can do abdominal exercise, you can do ab crunches, you can do ring dips. This is very challenging, actually. I would recommend you start with your feet on the ground. You can do pull-ups. With pull-ups, for a deconditioned person, you would probably want to do resistance bands to support the body. You can do bicep curls, you can do tricep extensions. So the rings are an affordable way of doing all sorts of exercises. You can do legs as well, pistol squats, I'm showing you an example of. The great thing about calisthenics is, again, it's a compound exercise. You're putting a stress on the whole body. You're activating that central nervous system. You're getting the brain to develop. So I love those things. Powerlifting. Powerlifting is the purpose of lifting more weights for the sake of lifting more weights. It is very dangerous. I'm not a huge fan of it for the general population, but I admit I did do it because when I was in PA school, I went to a powerlifting gym and everybody was doing it. And so my max deadlift was 460 or 465 pounds. And I think I was only able to do this because I have very long monkey arms. And so I can get down to the ground and pick things up quite easily. So not a huge fan of this for the general population. Bodybuilding. Now, I do like bodybuilding. It gets a bad reputation because it's associated with anabolic steroid use. But bodybuilding is great because it's about progressive overload. It's about training the muscle to make it bigger, denser, stronger. This is what all our patients need to do. And it's with progressive overload. So you slowly increase the reps or the time under tension or the volume to grow the muscle, to grow the bones, and to grow your brain. Now, you can do this with calisthenics. You can do this with strength training. I did it with all sorts of modalities. But the typical rep ranges that are classically done is 3 to 4 sets and about 8 to 12 reps. That's classical hypertrophy bodybuilding. The latest studies are really showing that it's overall volume that makes the muscle grow. So whether that's doing higher rep ranges or going to the gym more often, or that the whole total volume determines the muscle growth. Let's look at some classic bodybuilding equipment in a gym. Let me mute this. Cable overhead pressing, lat pull downs. And that's actually a close grip lat pull down. The dumbbell press. You can do an incline, you can do a flat bench. I prefer actually the incline bench because most people have an underdeveloped upper pectoralis muscle. It's easy to grow the lower ones, it's harder to grow the upper ones. So typically if I don't have much time, I'm always doing a slight incline, about 35 degrees to target the uppers. There's machines that can also be very efficient at targeting the uppers. I like assisted pull-ups for patients that can't pull up their own body weight, which is most of the population. So you go to the gym and it subtracts some of your weight so that you can progressively overload again. So if the patient can't get to the gym, so they say they travel all the time, there is resistance bands. They're portable. This one has a base plate attached to it, so you can bring this anywhere. I often will bring this with me on vacation, and you can do a full body exercise. You could do legs, you can do chest, you can do back, you can do deadlifts. It's great. I like resistance bands because there's variable resistance, so the amount of tension it changes. So the most amount of tension is when you fully are in the extended part of the motion. And then the least amount of resistance is when you're in the most vulnerable part of the motion. And that's where people can sometimes injure themselves with heavy weights, is when they're on the eccentric portion. So I like bands for that reason. CrossFit, I don't recommend CrossFit typically for the deconditioned patient just because there's a non-insignificant risk of rhabdomyolysis. These patients can hurt themselves, end up in the hospital. I've seen that before. And when I worked in the ER, rhabdo happens, kidney injury, because they want to compete, they want to beat everybody. Everybody's competitive, and CrossFit is a highly competitive environment. So it can be great if you have a good coach, but oftentimes there's not a good coach that cares for the patient and end up with rhabdo. But a good coach, it can be done right, but so we try to avoid. So what energy sources can the body use? Well, muscle glycogen, about 1 to 3,000 calories. Liver glycogen, your liver can hold it, and then your adipose cells. You got infinite energy in your adipose cells, essentially. The breakdown of carbohydrates, glucose, and glycogen involves both anaerobic and aerobic biochemistry. Energy is contained within the molecular bonds of glucose and is released during their breakdown in a process called glycolysis. So glycogen is the storage form of glucose and is broken down as glycogenolysis. So that's something important all our patients need to understand is when the food that they eat, it should store in the muscle. It shouldn't store as fat. If that's happening, you got some problems. Okay, this is what I was talking to earlier is my CGM analysis. And so during the tennis match is when I would see a spike of my glucose up to about 130. So that's like and then meals like earlier in the day, a little bit lower. Maybe my glucose would go up to 120. Hypoglycemia post-tennis match, that would happen pretty commonly as well. When I finished the match, boom, blood sugar would drop. I'd feel okay. I mean, my blood sugar would go from 130 to 73 after an intense tennis match. That's just normal. That's just how my body is. Let's talk about cardio. That's aerobic metabolism and carbs versus high-fat diets for fuels. So the old way of training, which all us athletes were told, is you need to carb load. You need to eat a bunch of carbs before training. Now, modern keto athletes are finding that's not true. That actually, if you're in ketosis or you're eating fat for fuel, it's great for long distance training, aerobic marathon cycling, because if you're already in a keto state, you're never going to hit the wall and you just continue to use fat for fuels. Now, we can use this for our insulin resistant and diabetic type 1 patients. There's some studies that, in fact, type 1 diabetics on insulin therapy who consume carbohydrates are at significant risk of developing obesity, heart failure, and retinopathy in such standard practices. So what we can do instead is we can suggest low carbohydrate diets for these patients, just like we would for an endurance and aerobic athlete. Some athletes are different and they'll argue otherwise. So it really is up to the athletic individual. What is anaerobic metabolism and carbs versus high-fat diets? So anaerobic is high intensity training. So that's what I do. I play tennis. It's an anaerobic sport. I do strength training. Again, it's an anaerobic sport. Anaerobic carbohydrate oxidation, particularly from muscle glycogen, dominates at higher exercise intensities, whereas fat oxidation is more important at lower intensities. So maximal rates of fat oxidation occur at 60 to 65% VO2 max. So why is that important? You can send your patient to get a VO2 analysis, and this can tell them what level of intensity they need to be training at to burn fat. So a lot of people think they need to train super intensely, like they need to do HIIT training or Zumba to lose fat. And the reality is probably much less than that. It's probably around 60% of their maximal exertion. So that's a good test for patients to do. For me, I found that I have maintained relatively lean and I've trained my body over a lifetime intensive tennis training that I just burn fat very efficiently with high intensity training, which is tennis. But again, every athlete is different. I've also noticed that if I do keto or carnivore diets, my maximal power output is less. And so that's also consistent with some of the studies here by Pauli et al. Potentially, some athletes may not respond. I know Sean Baker, as Dr. Richard alluded to, he's a great athlete. He does carnivore. He does fine. Not me. I'm not that case. I need a bit of carbohydrates for my high intensity training. So we should talk about cardio versus HIIT. Cardio, which is get on a treadmill, or high intensity training. Which one should you do? Well, it just really depends on the person. You do what you like. If you don't have a whole lot of time, I would go HIIT training 100% every time because it's more time efficient. You can do jump ropes, you can do kettlebell throws, you can do sprints. You can be done in 15 minutes, and you can get a similar effect or benefit as you with cardio training on a treadmill for about 40 minutes. So high intensity interval training has the potential to reduce cardiometabolic risk. It improves insulin sensitivity. Fasting glucose improves HDL, decreases hypertension, decreases weight. So overall, HIIT, might be a little bit better than continuous moderate exercise, but they're basically equal. It really comes down to the time and what you like to do. So again, examples of HIIT, tennis and sprinting. patients can sprint, right? They can go to a park if they're on a beach. Let me see myself sprinting here. Just running back and forth, stopping, taking a break, and sprinting again. Do that a couple of times, and it's great for burning visceral fat and improving your cardiometabolic risk. Or you can play tennis. I like that too. So here are some of my pet peeves in the fitness industry. Patients doing shakes as meal replacement. So shakes, protein powder is great. At the end of the day, I'm gonna go home. I'm gonna have a whey protein shake just to get more protein because I'm trying to hit about 200 grams of protein per day, and it's very hard for me to do that if I don't do a shake. My problem is with patients, they will replace an entire meal with a protein shake. That's not appropriate. The protein shakes are an additional add-on to consuming protein throughout the day. You need to be eating complex carbohydrates and protein throughout the day. But too often I have a patient that will come and they just drink black coffee in the morning or a green tea with honey. They don't eat anything until noon is when they do their shake, and it's full of one banana, strawberries, oat milk. They'll do a little scoop of whey and collagen because they heard collagen is good for you. But I'm like, okay, wait. How many grams of sugar are you eating per day? And they're like, well, I don't know. Well, calculate it. Get out a scale, count out how many grams of sugar you're eating, but they'll tell me, isn't fruit good for you? Yeah, it is. It's better than a Snickers bar, but the overall amount of grams you're consuming matters. So lo and behold, I had a patient this week. He would drink green tea in the morning and he would put 7 scoops of honey in there. And I was like, okay, that's 170 grams of sugar. And he thought honey was healthy because he heard somebody on a good meaning person, influencer, say honey is healthy for you. 170 grams of fructose in the form of honey. He would do a shake and then maybe eat a little bit of salmon at night. So maybe 30 grams of protein in the form of salmon, 170 grams of sugar. This is metabolic syndrome. And we saw that in the labs as well. And I see this always again and again. People doing shakes, drinking their fruit, and it leads to just overconsumption of carbohydrates and fructose and not enough protein. So most people don't consume enough protein. Not a fan of dirty bulking, of course, because fat is forever. You can shrink it, you can't remove it. Fearing the free weights, yeah, a lot of patients, and particularly unfortunately women, they feel that if they touch a dumbbell, they'll suddenly get bulky, and they'll. I had a patient that sat in front of me, and they said, "I don't want to get bulky," and I said, "What do you mean by that?" They're like, "Well, I don't want to look like you." I'm like, "What? Well, you think I look bad?" And they're like, "Oh no, I'm sorry, I didn't mean it like that." I'm like, no offense taken, but this is just like the thought process behind our patients that they think that if they touch a dumbbell, they'll suddenly look like me. I've been trying to get bulky my whole life. I still haven't achieved it. What else? Toning or targeted fat loss. This is a fictional concept. You're going to lose fat all throughout the body. You're going to lose it off your organs, your heart, your liver, off your intestines, off your midsection. So yeah, you're going to lose the fat on the midsection. Great, but you can't sit up your way to a six pack. And I know a doctor who I used to work with who did this, and that was back when I worked in the ER, and he walked in with sciatica one day because he did 100 sit-ups, crunches, and he pulled his neck, and his neck was hurting, and he had sciatica. It's terrible. Don't do sit-ups. I'm not a fan of those. Smoothies and juicing as a concept for weight loss. Yeah, you probably lose weight, but you probably lose muscle. You probably lose bone mass too if you do that long enough. But smoothies and juicing are high carbohydrate. They're high sugar. There's low protein in that. So not a huge fan of that. Waist trainers, just say no to that. And then pre-workout drinks are often filled with unnecessary sugar and caffeine and artificial sweeteners. If you want the bioactive ingredients, there's recipes for them. We probably talked about these on these lectures before. This potassium nitrite. There's tadalafil, it's a prescription medication. It can create a great pump. There's creatine, niacin, BCAAs, TMGs. All these are well-studied supplements that have efficacy in both the general population and disease states. But I wouldn't just consume pre-workout drinks. It's mostly useless. The GLP-1s, tirzepatide, semaglutide, not against them, but I think they're overprescribed without actually looking at the muscle, without actually looking at the DEXA scans and monitoring. So, patients will say, I lost 60 pounds on tirzepatide, semaglutide. Well, what did you lose? I lost weight. No, did you lose bone mass? Did you lose muscle mass? So no one's monitoring. You're not doing DEXA scans. You don't know what you lost in the process. So final thoughts, resistance training is key towards improving the metabolic health and decreasing morbidity and mortality and extending the lifespan. Focus on the compound movements if you're going to focus on one. Progressive resistance training means start slowly and make it harder gradually. Most patients will need a trainer. It's not going to happen with the 5 pound dumbbells that they have in their closet at home. I get that all the time. No, they probably need to shell out the money for a real trainer to monitor them because they haven't had an education in this. They've never heard of these concepts before, and they're probably going to injure themselves or give up if they don't have someone supervising them. High intensity interval training and cardio should both be utilized in a training. Nutrient density is more important than calories in, calories out, but both are equally important in the grand scheme of things. Prolonged fasting, calorie in, calorie out, and GLP-1s, they can negatively impact the patient if you're not careful. So you should be monitoring this with DEXA and labs. And then hormones is a whole nother lecture I can give, but hormones are very important in the older populations. They're not going to respond to a strength training program the same way as a 20-year-old would. It's an obvious thing, but it just needs to be said. Monitor the labs, do advanced imaging so that patients have something more to hold on to than just the scale. Good. That's all I have on the muscle centric medicine approach.
Great, Stefan. Thank you so much. That was really a whirlwind tour. Absolutely fascinating. I'm sure we have some questions. I want to start out with a couple myself. Just some things I spotted on the slides. You mentioned that muscle building results in less gluconeogenesis. This is an important thing, really, because gluconeogenesis is not really great. You want to burn glucose and not create glucose.
Yeah, I think a lot of these patients they're have an overabundance of energy. They're both, producing it themselves and they're consuming it and they have nowhere to store it.
You mentioned, you focus on high and increased insulin, which of course is crucial, right? This is the etiology of the metabolic syndrome, and most doctors never measure it, which is truly a scandal. And that is absolutely crucial. We have to be doing this on a routine basis. Uh, I saw you had DHEA and also DHEAS. What's the difference between the two?
DHEA, something you can prescribe. You can also measure it with certain labs, but DHEAS is just is a cheaper marker I use, basically.
Okay. You didn't, what about rest, right? You have to rest when you're doing a workout program trying to build muscle.
Yeah.
How often, how often should you do a HIIT session and how
Yeah,
much time
so
do you need to rest?
it it depends on their level of how many years they've been doing it. Like for example, I can train pretty much every day. It also just depends on your hormone status. Patients on therapy, they can oftentimes recover a lot faster, especially if they've been training consistently. While the patient who's deconditioned, who's never seen a dumbbell or the inside of the gym in their life, I mean, they're gonna hurt for days afterwards after an initial very light session. So it's progressive with time. That's the point of progressive training.
We both know the importance of electrolytes. Could you just say a few things about how to supplement electrolytes and the
Yeah,
importance?
I'm usually always drinking some level of minerals in my RO water, but when they do train, yeah, they're gonna have muscle cramps if they're not careful with supplementing sodium, potassium, and magnesium. They'll have twitchy legs at night, restless leg syndrome, twitchy eyes, especially when they start training and they're sweating and they've never done that before. They'll get electrolyte depleted. I mean, they've been sitting in an office for years and without a sweat.
You mentioned carb loading, which was a big fad. And this was pushed initially by Tim Noakes, who is a South African doctor and marathon runner. And he was quite competitive and he pushed the whole notion of carb loading and it caught on. And that's why, before the marathons, everybody used to go and binge on pasta. Then he developed type 2 diabetes from his carb loading and he went completely low carb.
Yeah.
From one day to the next, he did a complete turnaround and went completely low carb and he became an advocate for low carb lifestyle.
Wow. I
Tim
didn't know
Noakes.
that.
Tim Noakes. He's a great guy. All right, let's take a few questions. Dr. Richard Heckman, you're first.
Thanks, Dr. Hartman. I'll call you Doctor, Doctor of Metabolic Science. Thanks so much for your presentation. I have two questions, actually. One is for years, I have pursued a so-called vegan or semi-vegan diet, low meat diet, let's call it that, which turns out to have a lot of carbs. Like what we're eating for dinner tonight is so-called Egyptian lentils and rice. That's sauteed onions on top of stewed lentils on top of brown rice. I love it, but it's obviously a lot of carbs. And what's your comment about diets that purport to be healthy but use a lot of this kind of recipe? That's question number one.
Um, yeah, I'm not a huge fan of vegan diets for a lot of reasons. I have a lot of lectures on that subject as well. Um, yeah, you need to watch the protein to carbohydrate consumption there. Vegan diets, they could be great for ex energy, marathon runners. Again, it's that carb loading concept. But for muscle building purposes, the protein that you're going to extract from plant sources is going to be less than the protein you're going to extract from meat sources. So, if you're looking at overall calorie bang for your buck, the animal-based sources are going to be better for nutrient density, as well as lower carbohydrate, lower glycemic index, and better nutrient extraction from those. Vegan diets can be done, but the supplementation needs to be much more extensive.
Okay,
All
thank
right.
you. Second question is about 30 years ago, on the back of a magazine, I cannot remember what it was called, maybe Saturday Review, which kind of dates me, but there was this device that was sold. It cost in those dollars about $25,000. It looked like a combination of all kinds of devices. You lie down on it, you put your feet on these things, and your arms and something else. And the claim, which I thought was ridiculous, was that in 15 minutes you could do all kinds of exercise that took other people 2 hours to do. And as I think about it, it looks a lot like an HIT mega machine. I don't know if you have any information on this thing. It's probably not made anymore, but you're really saying that HIT is the best way for the average person to accomplish the metabolic changes that we're looking for. Is that correct?
High intensity interval training is the most efficient way. If you're gonna have only 15 minutes to do some exercise, you can get out in the backyard, you can do some sprints. Anybody can do that.
Thank you.
Yeah.
Dr. Gold.
Thank you so much. Welcome. It's good to meet you, Stefan. I'm with Dr. Heckman. I tend to just call people doctors who are doing the right thing, saying the right thing. So I'll try to be quick, but I also had a few different questions, and I'm also thinking in terms of a lot of patients who come to Goldcare. So I love when you said it's obvious, but it must be said. That's fantastic because things are not so obvious. So when you said women and hormone replacement therapy. I went and I screen captured your slide that said that, and it seemed like elderly women, yes. Middle-aged women also you feel should be on hormone replacement therapy to gain muscle?
Yes, all of them.
Okay. Okay.
Yeah.
I also screenshot because we have questions on this too, liposuction, which I've always thought was kind of silly and not medical, but it was kind of interesting. I'm wondering if you think liposuction is an adjunct that should be added if a person is already doing other things correctly. Like, is that a reasonable thing to say?
We need a plastic surgeon to
Separate
come on and
cost.
give us that lection. I want to hear a plastic surgeon defend plastic surgery for metabolic health purposes. I'd like to hear that lecture.
No, well, I was just curious because when it said, I know fat cells can only shrink and they cannot be removed.
Yeah.
But from your perspective, that's ridiculous, right? Like you wouldn't. Okay, fine. No problem. And then the last thing, some of our patients do want to be on the GLP-1 agonists. And so I really enjoyed hearing what you said. If we do that, they should be monitored with a DEXA
Yeah.
kind of regularly. And it said used with anabolic steroids. Would you prescribe them at the same? Okay,
Yeah.
very interesting.
Yeah, I do that as pretty much a protocol here. When I have a patient that wants to be on GLP-1, all right, what are we doing? What's the protein like? Okay. Do you have a personal trainer? Are you training? And then, all right, we want to start a GLP-1. we should probably do something as basic as DHEA or testosterone. There's other anabolic steroids that can be prescribed as well in conjunction to help preserve their bone and muscle so that we don't lose the precious material when we lose weight on a GLP.
So, okay, we should probably have you back or answer some questions about the protocol for women on GLP-1s. I would love to have more information on that. I myself am not educated. I don't know that many of our providers are educated on that. Thank you.
Sure.
Christy,
Thank you so much. That was awesome, by the way. So I'm a registered dietitian and I was a sports dietitian as well at USC. So this is like right up my alley. I loved and enjoyed every aspect of your talk. Thank you so much. I have a few questions. One is I would love to know how you would say and suggest to use creatine. Would you say pre-workout, post, and how much? And does it obviously it differs, obviously, if you're doing bodybuilding versus just like a regular person, but specifically for females, because I feel like that's really, really important. And I've been reading a lot more research on it.
Yeah. I think every patient needs to be on about 5 grams of creatine per day. The timing doesn't matter. It just matters that they actually take it. It loads with time over several weeks. Approximately it's going to reach peak in about 8 weeks. And then that's when you have that maximum saturation in muscle. That's where you're going to have that better utilization for that creatine ATP phosphokinase system, that basic energy system that we all use for that initial burst of energy when we do that sprint, and it resets every about 60 seconds. That's why, tennis is such an interesting sport. I think they may have inadvertently, before they even discovered, because tennis is a very old sport, they learned that after a point, you need to rest about 60 seconds. And that's about the time it takes for the creatine ATP phosphokinase system to regenerate so you can go and do the next sport, next point. But, anybody should be on it. Creatine improves height velocity growth for children, so it makes them taller. It improves IQ points. It prevents Alzheimer's dementia, so it improves white matter in the brain. It improves bone mass, muscle mass, and again, it improves energy. So if you have a fatigued patient, of course should be taking creatine. As far as loading it, you can load it though. There may be more gastrointestinal side effects with loading creatine, and so I don't usually do that because I don't want them to not use creatine. I want everybody to use creatine. And women too. Although the women will say, Stefan, you made me gain weight. And so I'm the bad PA who made the patient gain weight. But what they gained was they gained better hydration. They're not as dehydrated. Talk to our nephrologist friend here, Richard. He doesn't want a kidney dehydrated. The creatinine is not toxic for the kidneys. And if you send a patient to a conventionalist and they're on creatine and they run a CMP, they'll be freaked out because the creatinine will be elevated, and they'll send the patient to the nephrologist for a kidney biopsy when what they should have done instead is make the patient better hydrated and order the cystatin C and do the proper calculation, the cystatin C creatinine GFR calculation. And then you learn that the patient is perfectly fine and they were just taking creatine.
Wow, interesting. And then two quick questions. I know we have somebody else, but you talked a lot about like the carbohydrates, but protein. What would you suggest in terms of for females? Well, males and females, but I'm specifically thinking about females in terms of, there's been a lot of talk about 1 gram per per pound of body weight. I feel like across the board, most people are low in protein, so specifically females. So I just would love your thoughts
So
on
we
that.
now have the technology to know exactly how much protein they should be consuming per day. You can sit on a body anthropometric scale, and those are give you a rough idea how much bone mass you have and how much muscle mass. Because the calculation is lean body mass times 1 gram per pound of lean body mass equals how much protein you need to eat to maintain. If you want to gain muscle mass, it's 1.5 grams per pound of lean body mass, and that's your muscle and the bone. It's not your overall weight. So you need to get in the DEXA or get an idea of your bone and muscle to make that calculation. I mean, I've eaten as much as 2 grams per pound of lean body mass per day when I was trying to gain a lot of muscle, and that was very effective. When you put patients on high protein, they're like, "Wow, I feel great." And women need it as well as men.
Yeah. totally agree. What do you think about HGH?
Yeah, HGH is fantastic. You know, I measure IGF-1 as a proxy marker of growth hormone. So optimal levels will be, if you talk to Dr. Thierry Hertog, he'll say optimal levels are between 250 to 350. I rarely see an adult person above 140. When I measure pediatrics, their IGF-1 will be, you know, depending on age, 300 to 500. And then it drops off in most adults past age 30. And so that contributes to a lot of problems, loss of bone density, poor sleep. I know growth hormone is probably the best thing I've ever found for people who can't sleep. It helps their joints. They don't hurt as much. They have better energy. Dr. Hertog has pioneered a lot of the research in this. I mean, from infections to Alzheimer's to cardiovascular disease, everything seems to be reduced with proper growth hormone optimization. The difficulty is acquiring it and injecting it. I mean, I did an experiment on myself this past year. I ran 3 units for about 8 months, and I gained a decent amount of size. But I gained a little bit too much weight for tennis. So I went from 178 pounds to 192 pounds, and I was just too heavy on the tennis court. So I stopped it, and I'm back down to 180, which is good timing for my tennis match tomorrow. I'm playing a pro circuit. I just can't move at that weight. I got too heavy. And I think some of it was too much water weight and possibly even a little bit of fat, because I noticed my face was a little bit rounder on it. So I gained a little bit of fat on it.
That's exactly what
Thank
I
you.
told you, Stefan, when I came to see you.
Yeah.
But you're getting too bulky for tennis.
I was getting too big. Yeah, so I took your advice. I went off the juice. Yeah.
Thank you so much. I appreciate all your.
Jennifer Allen.
Okay.
Yes.
Well, thanks, Stefan, for being here. I appreciate it. I'm having to relearn, as we were discussing at the beginning of this, from allopathic medicine. I had a question because you were saying that we need hormone replacement when we're older, but what about people who have a hormone responsive cancer, whether it's breast cancer, prostate cancer? Where does that factor in? Is that still possible if they're doing the other things to beat the cancer, like eating well?
Yeah, well, if we're talking about prostate cancer and specifically, we have to look at the data from Dr. Abraham Morgenthaler, who has pioneered a lot of the studies in testosterone replacement therapy with metastatic prostate cancers. What he's found is if you get a proper discussion with the patient, I mean, it improves their quality of life dramatically, and it doesn't increase the rate of progression of the prostate cancer. I know I'm not sure, even with his data, that we know the answer to that one. I think it's a case-by-case scenario, specifically for prostate cancer and testosterone. I don't think it induces prostate cancer. You know, if anything, I find that patients with the largest prostates have low testosterone in my practice, and they've never had testosterone therapy. So I don't think testosterone causes the prostate to grow as a rule of thumb, but everyone's individual. I mean, I have patients that literally tell me that they feel their prostate more irritated when they don't take a DHT blocker. On the flip side, for women with breast cancer and hormone positive breast cancer, and they're probably getting treatment for that at the time, and they're getting estrogen blocking therapies. Unfortunately, those cause a lot of problems for women, you know, bone loss and all sorts of neuropsychiatric problems from lack of estrogen in the body. But once they have that treated, I don't see any reason not to do estrogen. I mean, if they've had, you know, resection of the breasts and so forth, they've completed. You know. And again, that'd be a discussion with the patient.
So I know usually that's like they say 5 years, and then they say you're in remission. So, and I know with the prostate, it seems like the urologists have always put the men on hormone blockers. So,
Yep.
well, is that going to be a problem?
The deck is stacked in allopathic medicine against hormone replacement. That's for
Yes.
sure.
Yeah. And how do we get the DEXA scans? I mean, it's because I think of DEXA scans as looking at bone density, but does it look at more than bone density? And I just wasn't aware of that.
No, you're right. Conventional imaging centers, I've asked them to upgrade their machines. They won't do it. They said the software costs like $20,000. I'm like, I'm going to send you more than that volume eventually, but they won't upgrade. Maybe we can encourage them all to upgrade their systems. They can all do it. All these GE DEXA scanners, they can do it. They just need to upgrade the software. But the machine I looked into, it costs about $100,000 if you want to get one yourself, and it's like a dedicated body composition DEXA scanner. But there's various facilities and entrepreneurs that will have bought these machines possibly in your area. So you just need to Google for it.
You can also do
I'm gonna,
bioimpedance.
Yeah, that's okay. Yeah,
because
All
I
right,
know
I
I've got
think
a
Doc,
smart scale, so
yeah, smart scales.
that helps me to know if I'm
I think
getting the muscle mass when I gain weight, or if it's fat.
That's good.
well, there are objective measures too. I mean, how much weight can you lift,
That too,
right?
that matters a lot. Is your strength improving?
And the waist, measuring your abdominal circumference
Yep.
at the widest part is a useful measure. Certainly more useful than just, BMI.
Right. Exactly. How the clothes are fitting. Patients will
How the
always,
clothes are fitting.
exactly,
Yep.
they say they need to buy a whole new wardrobe when they do strength training programs.
Dr. Heckman, did you have another question or you just left your hand up?
I think he's muted.
Yes, I did have another question. It's a shopper's question now.
You've already
This
had two.
X.
You've
Uh,
already had
I,
two. I'm just warning you. Okay.
well, this is something I forgot to ask on the second question, which was this X bar 3 or X3 bar device. What is the cost of that? And does it come with any kind of guidance as far as progressive use of the HIT method?
Yeah, so the X3 system, it doesn't, so the owner of that, the inventor of that is Dr. John Jacquish. I don't think he actually does any sort of cardio or HIT. The only thing he does is that X3, and that's his like whole deal. And his goal with that is one set to failure with variable resistance. And he claims that that's really all you need to do to gain muscle. We have that system. It's about $500. We have like 3 of those at our gym. We also bought his vibration plate technology. So you can put those resistance bands and you can stand on a vibration plate. And it's known as the OsteoStrong system. It's designed for improving bone growth in osteoporotic women. And I'm actually a strong believer in that. And there's a local pharmacist here who opened up a facility called, it's an OsteoStrong facility, and he has women there doing this sort of resistance band on the vibration plate technology. But it doesn't involve like classical like sprinting or jump roping. It's just going to failure on every exercise. That's what it's involved in.
Thanks.
Yeah.
Are there any more questions before we let our guest take off and get back to the gym for yet another workout today?
Yeah, maybe sauna.
One of the things which should be obvious to you all, I forgot to mention it in the introduction, is that Stefan sees patients. He's a real clinician, and being a clinician is crucial. I think if you want to advance our art, you have to actually have skin in the game and see patients.
Yeah, I just want to add, I did notice that. I noticed also that you are like a lot of scientists, you will actually try something yourself to see its validity and and compliance, right? You know what I'm saying? Like that to me is to some extent a mark of a scientist. I know that you are starting to learn that Goldcare does things differently. We intend to break the mold across the board. Um, from the type of experts we bring in. We bring in people who are expertise in their area, no matter what degrees they have after their name. We've learned that people with lots of degrees aren't always the experts and aren't always being truthful. So I want to thank you for being here tonight, and I'd like to welcome you to come again, and I hope you do.
All right, appreciate it. Big fan.
Yeah.
Well, thanks so much, Stefan. Let you go, and we'll get your certificate on your way on its way to you soon, hopefully.
Okay, cool.
And we'll talk soon, my friend. Okay.
Thanks, everyone.
Thank you.
Cheers.
Thank you, Dr. Amberly.
Thank you.